I'm going to ask Shireen, Brady, and Marion and Nigel to join us at the head table, please. Okay, folks, we're going to open this for discussion. Obviously, this is a slightly controversial issue, and I'm sure that people have very different perceptions or feelings or insights into this question. I would urge folks not to stand and give a talk. Please keep your questions concise and your comments concise so that it then gives everybody a chance to participate. So please, I urge you, there are microphones on both sides. You will need to use the microphones if you want to ask a question. So please line up, but I urge everybody to please keep your questions short. And perhaps if you could identify yourself as well, please. And who's your question addressed to?
It's a comment. My name is Jane Sandlin. I'm Professor of Women's Health from King's College in London. I just wanted to inform you that we have nice intrapartum risk guidelines. You might be interested in the process for how they're created. They're created by doing a systematic review of the international evidence, and a consensus stakeholder panel then agrees the guidelines. Now, these guidelines cover a whole range of factors for intrapartum care for low-risk women, but contained within that is a 3-page list of risk factors about which women would be advised to give birth within an obstetric unit. And for those of you who don't know about it, I think it's probably a very useful resource for you. Could I also point out that quite a lot of the studies that were mentioned in the last slide have actually been incorporated into a Cochrane review of midwife-led care. And it's probably better to look at the whole review rather than the individual slides.
Thank you very much. And you'll be here at lunchtime so people can ask you for the background information. Okay, Dr. Charvanek.
Ben, I'll keep my comment short. Frank Charvanek, Chair of OBGYN at Weill Cornell in New York. One comment while we're at this stage. In the Netherlands, which Dr. Armstrong mentioned, is the country that has the most experience with home birth, the most trained midwives, the greatest experience with transport and counseling women. I want the record to show that it's considered a privilege to have a hospital birth. Women must pay out of pocket 250 euros for the privilege of having a hospital birth. In spite of that, over the past 20 years, the rate of women who have gone hospital birth has changed dramatically, from 38 to 23%. It's increased from 23 to 38%. So I want that on the record, that there's a great number of the rate of hospital births is increasing dramatically in the Netherlands over the same time period, in contradistinction to what we've heard in the United States. I just want to put that on the record.
Thank you. Dr. Armstrong, would you like to respond?
Dr. Charvanek is correct that more women are seeking hospital births in the Netherlands, but I think the reasons that they're doing so are complex, and I wouldn't necessarily infer from the trend of increased hospital births that women necessarily feel unsafe in home birth settings in the Netherlands.
Any of the other panelists who would like to comment on either questions we've had so far, please feel free to step in. Okay.
I have a question related to that last statement, and that is, we know the epidemiology is changing in pregnancy, and the health of women coming into pregnancy is not what it was 30 years ago. I'd like the panelists to comment on that, because that may have more to do with why it is people are perceiving that they may have an issue with the delivery.
Okay. Would any of the panelists like to respond to Dr. Hayes?
Maybe more generally, I think this issue of perception of risk we could dig a little deeper into it, I think. I think the comment that Dr. Armstrong made that people perceive themselves safer in the locations they choose is a very insightful one. I think, however, I don't think the 20th century invented the concept of risk. I think if you read older books, people had risks. But the question about risk is always, what can you control? Michel de Montaigne, when he was writing in the 17th century, said he'd lost several of his offspring in infancy. He said he had regret, but no great pain. Because to lose a child in infancy was normal, understood, and unpreventable. And most importantly, unpreventable. Now, in the 20th century, the likelihood of a woman dying in labor dropped 100-fold, 100-fold from, so people are aware of that. And then suddenly the possibility of control of something which seemed always inevitable, the death of an infant, the death of a fetus, the death of a mother in labor, changes perceptions of risk, and controllability becomes an issue. And that's where I think the idea that it's entirely a manufactured notion, risk, it does come from observations made about how people have been able to control risk. I think risk prior to the 20th century was not so focused on medicine, where risks were essentially uncontrollable until quite recently. But in other areas of life, people certainly took actions thinking they were at risk all the time.
Anybody else like to comment? Yes, please.
I would, if I could, Dr. Sachs, like to comment on Ms. Hayes' comments related to part of the explanation for increasing maternal morbidity and mortality may well be that in the U.S. in particular, that women are older and less healthy coming into pregnancy, and that's why our professional societies and HRSA and the CDC are locking arms with a number of other related or interested organizations to focus on this. And I emphasize the importance of figuring out how we can monitor, increase our maternal mortality surveillance, and decide on ways that we can really monitor severe maternal morbidity and track on these things. I think that monitoring what we care about is going to be part of the key to finding quality improvement initiatives that'll contribute to containing those problems.
Okay, we still have a lot of people who want to ask questions. Marion, did you want to step in? Okay. I think it's the perception, is this the left wing or the right wing? I think it's whether you're facing the audience or facing this way, but please, your name and institution.
Yes, my name is Ida Dara. I am a certified professional midwife with the North American Registry of Midwives, and my question is for Dr. McDormand and Dr. Paneth. Both of you mentioned the disparities in outcomes with non-Hispanic Black women and white women in the U.S. We've known that for a long time. The really surprising comment you both made for me was that 66% of the non-Hispanic Black women who delivered out of the hospital did not plan that. I think that's incredible. And what are we doing to find out why? What kind of research do we need to implement to find out why this is happening and what impact it's having on the overall outcomes and what we can do to change that?
Great question.
I think that the incidence of home birth is much lower for non-Hispanic Black women in general. Maybe fewer non-Hispanic Black women choose that option or have access to care providers that would give them that option. So therefore, the proportion that are unplanned maybe it looks large in comparison to the few that actually have access to planned home birth. As far as research, ways to get at that, I think you have to really ask women directly about their preferences and experiences. And I'm really pleased to know that the Listening to Mothers study is being done again, and I think Carol Sakala will be talking about that some. I think another thing you can do to promote birth options for minority women is to provide more services in areas and neighborhoods where they live, and to train more minority care providers.
Any other responses to the question? Nigel?
Yeah, I think it just gives that little statistic gives you a kind of insight into a demographic and a pattern of behavior, but its contribution to overall health disparities in infant mortality is trivial. It's just a very small number of women. Meanwhile, this is the big monster in the room. This huge health disparity between Black and white infant mortality has been going on for so long and has been so difficult to, should, in my view, is a research issue. We simply do not understand yet the cause of extreme preterm birth in African American women, and that should be a larger focus of research, because we don't have an intervention yet to offer. And I think medical care has very little to do with this issue at all. It's a primary serious problem which we don't understand. We have to try to understand. A lot of good research teams working on it, but we don't have the magic bullet yet.
Please, your name and...
Mariana Visor. I'm from the Netherlands, midwife and associate professor at the Zuid University. I want to remark to the comment that was just made. I want to emphasize that the costs for hospital birth in the Netherlands are only for women who have a low risk. So women who have a risk factor, medium risk, a free access to the hospital. There is a change going on in the Netherlands, and I agree with Professor Armstrong that it's very complex, that many things are involved in that there's a change in the population. Women are older, more primates, that makes a difference. There's, of course, fear is probably also an element because of the media role that's being played as well. And we look differently on risk, and not so much risk of home birth, but also with all more prenatal testing, risk is a different attitude as well. So it's a very complex and very multiple thing about changes in the Netherlands.
Is there a difference in attitude between the immigrant population and Dutch community?
Yeah, we have a very diverse immigration population from different settings, both from other European countries, but also from the Mediterranean, from Africa. And there's a cultural difference also from the background where they come from. And there's also a group of women that are lower social economic status, and of course have just, as you find in the United States, have a bigger risk of complications as well.
Thank you. Yes, please.
Sorry, home birth?
What is the percent of home birth in the Netherlands today?
I don't want to explain the whole system, but we differentiate between primary care and secondary care. And primary care is midwife-led care. Home birth rate is 19%, and there's another 12% of women who give birth with their midwife in the hospital who do not see an obstetrician and are regarded as primary care.
Thank you for the clarification. Next, please.
Hello, my name is Mary Lawler, and I'm a certified professional midwife. I have a home birth practice and also own a freestanding birth center, and I'm the executive director of the National Association of Certified Professional Midwives. And my question is for Dr. McDormand, and I'm wondering if you could comment on why you think the rate of home birth is increasing in the United States.
Well, birth certificate data doesn't have information on why certain birth options were chosen or not chosen, but I think there's been quite a large number of studies in the medical literature that have asked women directly about why they've chosen an out-of-hospital birth, and I think Dr. Armstrong spoke quite a bit to that literature. You know, women that choose out-of-hospital birth talked about their desire for a low-intervention physiologic birth in an environment where they felt comfortable and in control. Women also talked about the high rates of cesarean section, induction, and other interventions, which can sometimes come about in hospitals. And many women that felt that an out-of-hospital birth was safer for them and for their baby because they felt more in control of what was happening to them, and they could make more choices about having or not having different interventions and options. And also because they felt they were, you know, better able to avoid unnecessary surgery or drugs or procedures.
Thank you.
Thank you.
My name is Mari Rothman. I'm a certified nurse midwife with a home birth practice locally. And I just wanted to bring up a factor in choosing a birth setting that we really haven't touched on, and I don't know if is really part of this conference, but it's a significant thing that is a factor in our country when we talk about healthcare reform here, we really mean health insurance reform. And a lot of the driving force behind women's choice of where to birth is what their insurance will cover. And for that reason, there are a significant number of women who would choose to birth out of the hospital who aren't able to because they can't pay out of pocket and their insurance won't cover them. And then there's this other layer too with liability insurance that some Medicaid, for instance, in my state of Maryland, Maryland Medicaid won't cover a home birth midwife unless she carries a certain level of liability insurance that most home birth midwives don't carry. So there's a definite economic factor.
I hope we get into the economics of this issue because it's very important. Any of the panelists like to comment?
I think Mari's exactly right, and it's a complex issue. Studies have shown that the cost of a home birth is about 1/3 the cost of a hospital birth. But at the same time, if your insurance won't cover it, it's actually going to cost you much more. So it's a complex issue and something we need to discuss.
And we're going to be coming back to that for panel 6 tomorrow. Please.
Thank you. My name is Rebecca Spence. I'm an attorney and the founder of Legal Advocates for Birth Options and Rights. My question is for Dr. Armstrong. You mentioned that transfer is morally fraught, and I agree with you, but I also think that transfer is legally fraught for reasons of liability and for other reasons. In my area where I live in Northern Virginia, midwives are licensed, they practice legally, and some hospitals are reporting each and every transfer to the state licensing board on the midwife's license, and this presents a real challenge. At the same time, some commenters are calling for professional sanctions for providers who participate in planned home birth. So my question to you is if your research has indicated any way forward or any way to dial it down a notch.
It's an excellent point. You're right that it's not just morally fraught, that there are legal complications as well, and particularly the patchwork of state laws that govern who can attend births where makes this very complicated. A way forward, I can't indicate a way forward at this point, but I think part of it is it's embedded within this culture of this oppositional culture in which these polarized views of birth really contribute to the sense not of a common goal, but really of people working at cross purposes. And I think the levels of mistrust among communities of care providers are endemic and corrosive and need to be addressed. It's wrapped into the legal and moral complications, but we need to address that. And so I think you really are going to have to take a multi-pronged approach where you tackle legal reform and you tackle the process of rebuilding trust and respect among these different providers. Thank you.
I had mentioned this problem of trust with transfers to Dr. Stephen Chow, who's a bigwig with the Center of Medicaid Services. And, he pointed out to me, which I think is an excellent point, that doctors themselves, they transfer between different specialties all the time. You have a baby that has a lot of problems, you bring in the maternal and fetal medicine specialist, and that person isn't like freaking out that, oh, this baby was transferred, I wasn't in on what happened before this, and so forth. And so I think that it's really not an issue of transferring between providers or specialties itself, but it is really the core issue is that of trust. And doctors maybe don't trust that home birth midwife, and then they think bad things happen at home and stuff, and so then they start freaking out when they get that case. But if somehow trust and communication could be improved and promoted, maybe it could be just as seamless as transferring between different physicians and different specialties.
We only have another 8 minutes for all the questions, so let me ask the next person.
My name is Kate Bauer, and I'm the Executive Director of the American Association of Birth Centers. And this is really just a comment on the example that was provided during the first panel about the birth center in Michigan and the breech delivery. And I just wanted to point out that breech deliveries are outside the standards, national standards for birth centers. And Michigan is one of the few states that does not have licensure in place for freestanding birth centers. And I think it just points to the need for infrastructure in the remaining 20% of states that don't have regulations.
Thank you.
My name is Saraswathi Vaya. I'm professor of midwifery at University of British Columbia, a certified nurse midwife and a registered midwife. My question is for Dr. McDorman. Going back to the increase in home births in the United States recently, even among white women, I'm wondering about the slide first about the birth certificates that don't capture planning status, and that in fact whether the increase might be greater than we can appreciate because of those intention to treat women who were transferred. And linking it to the slide where you had your the states, the changes according to state, I wonder if there is some correlation and whether we can look from a research standpoint between those states which have increased access to licensed midwifery offering that option.
I think that's an excellent idea for a future study, and maybe maybe we can work on it together, or somebody in the audience wants to do it. I should mention that there is an agreement now with NAFSIS, which is the State Association of Vital Statistics Registrars, that all states will adopt the new birth certificate by January 1st, 2014. So hopefully we will have much better data very soon.
Thank you.
Good morning. My name is Claudia Booker. I'm a certified professional midwife in this locale. And I wanted to follow up on a comment that Mari made, and also this discussion about the over 60% of African American or people of color having indicated on a form that their birth was unplanned. In the last 3 years, since the number of home birth midwives who accepted Medicaid payments has disappeared from this part of the country, except for Virginia, I have more and more potential and old clients who are now practicing free birthing. It is a growing style, preference for birthing without the assistance of a care provider. And we are seeing those numbers raise substantially in Maryland in the last 2 years with the removal of some of our home birth midwives, and also the removal of the Medicaid provisions for home birth. And I think that that is something we need to really look at. I know my former clients that are free birthing put unplanned on their birth certificate as opposed to dad caught, because they think it will get them less attention. So I think that when we're looking at the issues of fear and trust and all those things, there's also a growing concern about not being able to pay for it, and who do I trust to have a baby with, and who can come and help me have a baby. It has far-reaching impact for prenatal care, postpartum care, newborn care. It's really something we cannot afford to look over in populations that may be compromised with health issues.
Thank you.
Hi, my name is Kathy Rule. I'm a nurse midwife. I'm director of women's health programs at A1. My question is, and especially in regards to the excellent presentation on our culture of risk, has any work been done to look at the mother's place of birth related to her outcomes? And I'm thinking about this because for my entire career, I've worked with a lot of Latina women, and for the last 12 years, almost exclusively, the women I care for here in DC have not been born in this country, and I feel like that's an important influencer on what their outcomes might be.
You mean where the mother herself was born?
Right, where the mother herself was born, which I understand does not equate with how many years she's lived in this country. But when you take care of a lot of women who have even especially birthed outside of this country before they came here, I see them as having very different views.
There's not a lot of research on that, but you're right. Certainly women who have experiences of other maternity care systems come into the American system with a certain set of expectations based on what, even women, I've seen this be true of primates as well, because even if you haven't given birth, you have an understanding of how birth works in a given culture. When you move to another culture, you often bring that with you. The other thing that I think sometimes operates here is that women who are disadvantaged socially, and that can be by virtue of their race or ethnicity, by their socioeconomic status, by their immigrant status, often perceive medicalized, high technology hospital birth as being a higher status and therefore more desirable kind of birth. And that's not an evaluation of risk or safety so much as it is as this is the way things are done by the people that I aspire to be like. And therefore that's a preference. But I think you're absolutely right that there is a lot to do there with cultural expectations.
Last question, if you could just keep it short, please.
Yes.
Thank you.
My name is Dale Reisner. I'm a maternal fetal medicine physician in the state of Washington, and this is actually more a clarification and a plea for ongoing look at this issue. In this, one of the comments that was made was somewhat disparaging of physicians' midwifery interactions as more being a cultural thing, and I want to insert the liability concern. So in the state of Washington, I got involved along with a couple of other practicing OBGYNs with the midwifery community in trying to improve the quality of the transport process. And I think that if we focus in our ongoing work on quality outcomes rather than who's providing the care, that we will make immeasurable progress. We have some pilot projects going on in our state in that regard. We've had some great, and it speaks to the things that all of you have already discussed, trust amongst providers and so on. But even in physicians who wanted to provide midwifery backup, they have been told by their malpractice carriers they could not. So please don't forget that that is a huge negative impact. And also that I think our state was very forward thinking in requiring insurers who provide malpractice insurance in the state of Washington to join together and to provide malpractice insurance for midwives who followed the state requirements to allow them then to have that coverage. So these are areas of creativity, I think, that we could incorporate in any ongoing research. And we have just fledgling efforts in the state of Washington, but it's been really rewarding so far. So there you go.
Thank you.
I could just make one comment. I'm Holly Kennedy, president of the American College of Nurse Midwives, and you're spot on this. And so as we go through the workshop, I'd like us to sort of keep this on the radar because there are state regulations that directly impact this and in how malpractice insurers either restrict or promote the collaboration of practice. So that's all I want to say.
Thank you very much. So please join me in thanking our panelists and discussants. I would like to thank all of you for keeping your questions short and the comments short. And we now have lunch, and as you can see, we're right on time.